So welcome everyone to another edition of the Fresh Air series. So we're doing something special today. We're going to do a multidisciplinary discussion to kind of show what happens behind the scenes in these discussions for interstitial lung disease. And you'll notice if you've been following these sections that we're all pathologists here. So we're going to take off our pathologist hats and just for this, for YouTube, we're going to play different roles. So in this, Dr. Sanjay Mukhopadhyay is going to be our pulmonologist or respirologist in this case. And I'll be the radiologist. So I'm not a radiologist in real life, but I play one on YouTube. And then last but not least, Dr. Sensano is going to be our pathologist in case, which she also is in real life. And so we're going to do this MDD discussion, and we're going to talk about some example type of cases. And so usually in these rounds, the pulmonologist or respirologist will present the history first. And so I'm going to turn it over to Dr. Mukhopadhyay, who's going to talk about our first case here.
Okay, thank you, Matt. As you know, MDD means multidisciplinary discussion. And usually the three disciplines are, a pulmonologist, a radiologist, and a pathologist. So I'm going to start with the first patient. I was thinking of doing this in a little, bass voice. Mr. X was from Michigan, like a like a true clinician would do. Mr. X came to us from Michigan. He's a 76-year-old guy, really nice gentleman. Uh, he's been he's been feeling a little, under the weather for about a year. It's been getting a little worse since October. Little cough, dyspnea. He went over to my friend Dr. Gross over in Wisconsin, and Dr. Gross treated him a little bit with steroids, gave him a little Z-Pack. Nothing happened. He didn't improve, and then he went over to the University of Cincinnati. Then he went over to Penn, and nobody could help him. So he came over here and he said, "Doc, I'm just not getting better. It's been about 9 months." So he gets short of breath when he walks about if he walks up a flight of stairs. It's been getting worse over the past about a year or so. No treatments have helped. So I took a little history. He worked as a just an office. He's just an office worker, a desk job, no exposures. His dad was a welder, but no exposures. His mom was a homemaker. Family history, no family history of pulmonary fibrosis. No birds in the home. No hot tubs. He does have a feather pillow, but he swears it has nothing to do with that. Um, let's see what else. He doesn't take any drugs other than the occasional, cholesterol medication. He takes vitamin D and this and that, but no drugs, no nitrofurantoin, no amiodarone, nothing that I could find in his history that would help. So I don't know what to do with this guy. I figured out that he has interstitial lung disease, but I'm going to let Dr. Cicchini talk about that. Is radiology in the house, by the way?
Yeah,
Oh yeah.
radiology's here, yeah.
Is Pat here? Is Pat here? Who's here from Pat?
Dr.
Okay.
Sensano,
Okay. All right.
I'm here.
All right, because we need the answer from you at the end. So he had when he came into our office, he brought an X-ray with him, and it just showed coarse markings on bilateral coarse markings, and our differential at that point was could this guy have some kind of CTD ILD or drug reaction or something idiopathic? We didn't know, but it looks like from the history that he doesn't have anything going on. So we did a high resolution chest CT, and I'm going to let Dr. Cicchini talk about that.
Great, thanks. Okay, so let's get this up and then. Perfect. Can everyone see the screen there?
Yep.
Okay, so first, this is the chest X-ray that I believe he came in with, and as you described nicely, there are coarse bilateral interstitial markings here across it, and so we did the high-resolution CT scan here, and as you can see, we have these reticular markings that have a peripheral predominance on the outside here. This cuts from more of the basal aspect of the lungs, and so you'd see on the sagittal films as well that it's more has a basal predominance to it. And then we have these spaces here, this honeycomb change, as we say, with these kind of thick-walled cystic spaces kind of lining on top of each other. I always like to say that to be a honeycomb, they have to be the size that a bee could crawl into. And I think many of these, we could get multiple bees at least in each of these things. And then there's also some traction bronchiectasis here as we have these airways that are dilated and expanded as they get out towards the periphery here. So the radiological differential for this case would be most likely a usual interstitial pneumonia type pattern. On imaging, I don't see any features that would be against it, and so the radiology in this would be most consistent with a UIP pattern.
So Matt, can you show us, because there's a lot of fellows, a lot of our pulmonary fellows are in the audience. Can you just show us where the honeycomb changes, and like, why is that not emphysema? Why is that not?
Yeah, so I think that area right there, I think I've circled in yellow there, is a nice area of honeycomb change. And the reason it's not emphysema is because it has these white surrounding areas around it. It's this thick-walled spaces here. And so emphysema, you shouldn't really see this thick-walled change to it. It's really just empty spaces of lung. And so see that we have all these areas highlighted in this more dense area would be in keeping with honeycomb change.
I see. Now, my colleague, Dr. Boondoggle from Pennsylvania, brought up this question of sarcoidosis. So do you see any features of sarcoidosis on the, what would you see if there was sarcoidosis?
Well, sarcoidosis, this is the wrong series to look at, but we'd want to look at the mediastinum and make sure that there's no enlarged lymph nodes that are calcified. But sarcoidosis can also cause an interstitial lung disease as well. And so I think they can have overlapping patterns to the appearance, but I just play a radiologist on TV, so I would defer that more challenging question to someone who is more board certified in radiology than I am.
Now, let me tell you that, when I saw this CT, I didn't have your expertise, Matt, so, but I thought this is probably UIP, IPF, and the reason that we sent this patient for a biopsy is that the outside radiologist was not fully committal as to whether this was UIP, and so we thought we really needed a biopsy in this guy. I was gonna start him on our new antifibrotic drugs, and before we did that, we wanted to have a definitive diagnosis. If I knew that it was clear cut, UIP by radiology, I wouldn't have even gone for a biopsy. So let's turn it over to Pat. Pat, are you in the house?
Where's Pat? Yeah. We are here. We got the biopsy. I'm surprised to see these radiological findings. I'm going to share my screen. This is the biopsy. Where you see, I don't know, they haven't written where the biopsy was taken from, which lobe. I guess it's upper lobes, because I don't see here the honeycomb we were seeing in the TAC, in the CT, sorry. What we see here is a section of lung where that it's affected patchy, in a patchy way. It is more, it has fibrosis here and it's more normal here. If we go down, we see that here we cannot see honeycomb, but we could say we see some destructuration, that the structure of the lung is a bit lost. I saw also we see some inflammation in the fibrotic areas.
Now, Dr. Sansano, can I ask you what those blue round things are? The blue.
These are follicles. Are follicles.
Your colleague, Dr. What's her name? I forget her name. She once said that when you see those, that means a connective tissue disease related ILD. So
when you see many, and especially in my opinion, when you see it in preserved lung and in airways and in pleura, I like to comment that CT CTD should be looked for. But in a case where there is fibrosis, we many times see some follicles and have no meaning. These follicles have no meaning.
Mm-hmm. Do you see?
We don't see many. I don't see many. I don't see many. It's a pink biopsy, not a blue biopsy. And what I was about to say was that I could find some fibroblastic foci, not a lot, but there's patchy fibrosis, some fibroblastic foci. And what is more important, we see normal lung that has no inflammation and no other features. So it could be it could be UAP low confidence. With joining these findings with the TC, it could be a UAP.
So if we told you in the lower lobes there was lots of honeycomb change, and it looks like those just weren't sampled from a radiology perspective, would that fit with a UIP?
Yes, if I got the biopsy from the lower lobes, I don't know where the biopsy comes from, but I guess it's not from the most affected area.
Yeah.
Now,
do you see any features of hypersensitivity pneumonitis?
No. What I would like to see, if it was if hypersensitivity pneumonitis, I would like to see a bronchiolocentric inflammation, like this bronchiole. You can see it's normal. And I would like to see some giant cells or some granulomas or something. And the lung that is not that has no fibrosis is perfectly normal.
Okay, that's helpful.
So it sounds like we have a consensus around UIP. Would that fit with the clinical picture?
Yeah, I think that it's helpful to know that there's nothing else going on the biopsy. It's also helpful to know that you have a pretty high confidence of your UIP diagnosis on CT. And frankly, if I knew that before, maybe we could have spared this patient a biopsy and not gone to biopsy at all. Because I really don't, from the clinical point of view, this there's no obvious cause to this patient's disease, so that fits with IPF or idiopathic pulmonary fibrosis. I'm going to call him into my office and have a discussion about the antifibrotics.
Sounds great. Okay, well, I think we have a busy schedule here for our MDD rounds. Maybe we should keep forging ahead to our next one.
Yeah.
Mm-hmm.
So I think you saw this patient as well, Dr. Mukhopadhyay.
Yeah, this is Mrs. Y. She's a very nice lady from California. Came all the way here because the hospitals there are really, they're awful. Our hospital is the best in the country. But she came to us. She has just a long history of scleroderma. Poor lady has been suffering from it for a long time. Has had esophageal problems, problems with with aspiration and stuff like that, and has had lots of difficulties throughout her life, multi-system problems. And now over the past maybe 2 years or so, she's been having problems with her breathing. She's been having a little bit of a dry cough on and off. And she, I tried to get a history of whether it was somehow related to her environment. She has any, pet birds at home or a hot tub or anything, or whether it gets more when she leaves her house. It doesn't seem like there's any relation to any kind of exposure source or antigens. There's no other family history of interstitial lung disease. I did pursue the aspiration angle, because she has scleroderma and this esophageal problems. It doesn't seem like she has any problems with GERD, at least not at the current time. Maybe there's some old, so that we will be very interested in seeing whether there's anything that's related to aspiration in the biopsy and on the CT. But mostly she just gives a very non-specific history of cough and shortness of breath. We did her pulmonary function test, and she does have a restrictive pattern. So she does have a little bit also of a reduced DLCO. So we're really stuck here. She's relatively young, and I just want to make sure that she doesn't have something that we could treat with a immunomodulator. So we need you guys' help. So Dr. Cecchini, what could you?
Definitely. And so unfortunately, we couldn't get the films from this case because they're from California, but and they didn't arrive here in time for our review. I think the CT's in the mail somewhere, but I was able to go through the reports, and it sounds like there was a good read of it, and their description is somewhat of a non-specific finding. There's some ground glass and some particular markings. There's maybe a little bit of subpleural sparing that they've noted. And there's some pertinent negatives too in the report, and so we don't see any honeycomb change there, and there's really not a lower lobe predominance of the findings. They're kind of more diffuse in nature, and the ground glass is largely associated with the reticular markings. And I also noted the esophagus was a bit patulous, and which would be in keeping with the history of scleroderma. And so these features aren't specific, but they could be in keeping with a non-specific interstitial pneumonia pattern. But I should note that we don't really have specific features to tell us that on radiology, and that if the biopsy does show features of UIP, that's still possible as an early UIP. And so I would favor an NSIP, but in these type of cases, I would definitely defer to pathology.
Do you see anything to suggest aspiration? Because that's really the other major concern here.
Like I said, that wasn't commented in the report, but I don't think that they commented on any features of aspiration. But given that history of that patchless esophagus, they definitely could be aspirating.
Okay, that's very helpful. So let's move to the biopsy findings. Yeah.
So here I got this biopsy. I have this section of lung where you can see that compared to the previous one, we see many of these blue balls. This biopsy has a blue filling. When we go, and it's not patchy, it's diffuse. Whatever is happening to the whole section. And when we get closer, we see that the interstitium is thick. That is thick with, and it has inflammation on it. It has these follicles, and it has some lymphoplasma cellular infiltrate. The bronchioles also have some inflammation. There is bronchiolitis, cellular bronchiolitis. And I haven't seen any food particle or so. These are crystals. I haven't seen any food particle or something that made me think about aspiration.
That's helpful.
Something else I wanted to show you. I haven't seen pleuritis, but I saw this here. Sorry. I saw this adherence, this thing that I think it's an adherence. And I was taught that when there is a pleural adherence, it's a sign that there has been a pleuritis before in this area. So I think I would call this biopsy NSIP with lymphoid follicles, and I would add a note that you should check that it goes for with a collagen vascular disease.
Okay, that's helpful. So you don't see any UIP features, correct?
No, I don't see normal lung. Well, here is the most normal lung, but you can see it's not completely normal. It has an inflammation, and it's the only part. I don't see fibroblastic foci. I don't see normal lung, and I don't see honeycomb. Then this is not a UIP. It's definitely not UIP.
So I think for the purpose of the MDD discussion and for the registry, we're going to label this as a CTD-ILD or a scleroderma associated NSIP, if that's okay with both of you. Do you agree with that?
Yeah.
Final. I think that's fine. And we'll, what we'll do is have a talk with her about her immunomodulation. Maybe we'll have to switch it because she's not doing that great on steroids. Maybe switch it to another immunomodulator, or maybe, down the line, move to an antifibrotic. We'll have that discussion with her. Okay, thank you both.
No problem. Okay, so I think we're moving the last case of our agenda here. And so I think you saw this patient as well. You look like you had a busy day in clinic there, Dr. Muthupadia.
Busy day in clinic, the, these
Wow.
Californians are just not doing a good job with their patients. All right, so should we start with case 3?
Yeah, that'd be great. Thanks.
Yeah, so this is a very nice lady. She's from the south of the country. I forget which state she's from. Came here with her husband. Very nice people. She has a very interesting history in that she gets very short of breath and starts coughing when she is at her house. But when she goes on vacation to Florida, everything clears up.
Oh.
I'm like, so what is going on? So what's going on in your home? And it turns out that she has a parakeet that she's got a parakeet that she's had for many years. She really loves this thing. She's not willing to get rid of it. Actually, she's very, very attached to it. It's like the family pet. And I broached that discussion with her. The idea of trying to see if she could get away from it for a while. But other than the occasional vacation, she doesn't. And then when she comes back home, she gets very, very symptomatic. And it seems like there's some sort of a relationship to that. And but that's what her symptoms are: cough and dyspnea, which are sort of episodic. And it's been getting more and more to the point that now she's getting, her shortness of breath is getting really, really debilitating. And I think I have to now convince her of what the diagnosis is before I try to, um, persuade her to at least get away from this bird for a little while. But we need to have a definitive diagnosis because there's several alternative things. She had a brother who she said had some kind of a lung disease in the past. So familial IPF is something we're thinking about. We're worried about other things. She doesn't take any drugs. There's no nitrofurantoin or amiodarone, no immune checkpoint inhibitor for any reason. So I don't think that this is drug related, but there is the question of whether this can be some sort of familial interstitial lung disease. Could this be, she had a little raised ANA at some point, and she's occasionally had a rash. So we were thinking, could this be some sort of IPAF or along that spectrum of things? So that's our differential here. Is it IPAF, familial IPF, hypersensitivity? So we're hoping you guys can shed some light on that.
Definitely. So we have the films on this case. Let me see if I can share these. Okay. Do you see the slide there?
Yep.
Perfect. And so this case is a very classic example of the finding here, so much so that there's a colleague of ours that saw this case, and we've actually was part of a teaching presentation for some residents, and I think it nicely demonstrates some of the findings that we would see here in hypersensitivity pneumonitis or HP. And so it's often referred to as the head cheese sign based on this, I believe it's got a type of lunch meat or some kind of delicatessen meats where you have this meat embedded in this gelatin-like material, which I have to admit I've never actually tried myself, but I don't really know if it's good or not, but so this is the picture of this head cheese, and then these are the images from the films here. And so what we describe is this mosaic attenuation where we see varying densities that range from this ground glass, which we have nicely in this orange arrow, to these less dense areas, which are these air trapping with this purple arrow here. And it's diffusely throughout the lungs here. Often you can see an upper lobe predominance as well. And one of the keys to the diagnosis here are these expiratory films. And so these are taken in the expiratory phase of respiration. And this can make the features of hypersensitivity pneumonitis more pronounced. And this really brings out this mosaic attenuation where we see these areas of lower density of which are air trapping. And it likely relates to the fact that a lot of the disease process is going on around these airways that prevents the air from getting out in the expiratory phase. And so it really makes these features more pronounced. And so from a radiology standpoint, this would be most in keeping with a hypersensitivity pneumonitis or chronic HP. There's not definitive features of short telomeres or other familial features of interstitial lung disease on imaging. And there's not really great features for that would tell us it's connective tissue disease, ILD either. So from the radiology standpoint, we can't do much in terms of helping that, at least from my perspective as a pseudo-radiologist.
Okay,
So
that's helpful. I think the radiologist at the outside facility was not that, wasn't that sure, gave a big differential diagnosis for
okay.
ground glass opacities. And that's why we went to biopsy, because we weren't completely sure whether there was a differential for this. But sounds like you're pretty confident that this is hypersensitivity.
Yeah, with that degree of air trapping, that increases my confidence, but there always is a differential for these things, especially with
Yeah,
the ground glass.
I think that's why path can be helpful, because we've seen cases over the years where it looks pretty compelling, and then the path just turns out to be completely different. So we want to just make sure. So Dr. Sansano, what do you have for us? What's the answer?
Well, in this time, I completely agree with Dr. Cecchini. I'm going to show you in a minute. Here you see the lung sections where you see again a patchy pattern, and it's again blue. We see inflammation. We can imagine there is inflammation. When we get closer, we see the distribution of this blue. Blue is around bronchioles. Then we see bronchiolocentric pneumonitis. And here, inflammation. In the periphery, we see less. We don't see fibrosis. We don't see fibroblastic. Well, here in the periphery, we see a lot, but we don't see fibrosis. We don't see fibroblastic foci.
Now, do you see? Can you show us some of the granulomas, because they're just for our fellows to see what they look like, the granulomas, or
I'm looking for them. Here you see bronchiolitis. Here I saw some very beautiful in this section, for example. Easy to find because there were calcification on it. This is a giant cell with calcifications. Probably cannot see the giant cell, but it's there. And this is a harder to believe one, but you have to believe that these guys here are forming a granuloma. But are the kind of granulomas that HP has. And there are many others like this. Here again.
Mm-hmm. So what is that stuff in there? Is that something she's aspirating or inhaling, or what is that material in there?
It's a product of metabolism. It's not aspirating. It's aspirated material.
Interesting.
It happens in HP. It happens also in sarcoidosis. It's not aspirated.
Okay, because she worked for a little while in some sort of a chemicals plant or something, and I was just worried that she might be inhaling something that might be damaging her lung, or vaping or something. But that's not what you see here, right? Okay.
That's all. It's a bronchiolocentric interstitial pneumonia.
Okay.
And it's according with your history or with your suspicion of HP.
Yeah. Well, that fits. She has a very characteristic combination of obstructive and restrictive disease. She has a very compelling exposure source. She's been responding fairly well to corticosteroids, but I think the key here is going to be to convince her to, stay away from the bird or get rid of the bird. That's going to be quite a challenge to do, because, there's an emotional connection there. But it really helps to have this MDD discussion, and our final diagnosis is hypersensitivity pneumonitis.
Sounds great. Well, I think those are three excellent cases and examples of how MDD can be utilized to arrive at a diagnosis for patients to help improve their care. I just thought we could take a few minutes and discuss some of the challenges that, from at least from the pathology perspective, now I'm taking my hat off as a pseudoradiologist, that we can discuss as a
Yeah,
group.
for sure. See, Matt, I think we should all discuss how it happens in our places, because one of the problems with MDD is there is no definition of what an MDD is, or how many people there should be, or how the diagnosis is made. It's very haphazard, you know.
Mhm.
Like you get three people in a room, which is great. It's very, very good to have each other's perspective. But then how that, how a diagnosis comes out of that is very arbitrary. And I think one of the biggest problems in our setting is that anything that has a diagnosis actually doesn't come to MDD. So the
Okay.
things that have a clear cut diagnosis are never even brought to MDD. We only bring the cases that don't have a diagnosis. So by definition, the biopsies we have are either non-diagnostic, or they're non-specific. There's no answer, and there's nothing. So we are dealing with the toughest of the tough cases that don't have an answer. It's very, very frustrating for everyone
Yeah.
involved. I don't know how it is that do you discuss all your ILD cases at your MDDs?
We don't discuss all of them. We discuss a larger proportion, probably. Just we likely don't have the volume that you have, and so there actually is a nice mix of cases that are very challenging. But then there's also included cases that have actually some classic findings, and so um, it's a little bit easier in a way, right? And it's often good for because we have our trainees join, as well as the clinical trainees and radiology trainees that join as well, and so it can be more of an educational opportunity as well, for not only going over these challenging cases, which often don't have a clear-cut answer, but also some classic cases where it does all fit from the radiology, the pathology, and the clinical side.
So Irene, like I find at our place that um, often in these difficult cases, they're not really looking for a pathology answer, because they already know there is no answer from the pathology. They have a report. The report states, that it's non-diagnostic, non-specific, whatever. But they're often looking for advice from ILD docs, experienced ILD docs. Other people are calling in to ask, what should I do next? So the pathology said this, the radiology said that. What's my option? How do I treat? What else can I do in terms of biopsy? What should I tell the patient? So do you have that kind of thing there, that it's more of a treatment management problem rather than diagnostic, or is it mostly diagnostic?
No, it's the same. We don't. We also we do like Matt said, more or less. We don't discuss all, but we try to put some to reinforce our. But this is the most that we have, and I work with cryobiopsies. Then I have a lot of non-diagnostic biopsies, and what I feel that they don't want to own that, to take to give a treatment or to put a label only with one person's opinion. It's most in what I have to show in the biopsy. They have some questions. It's like, oh, we are going to give steroids. Is there inflammation? Is that just specific questions, not the diagnosis, because they already know that the biopsy has not a diagnosis.
Yeah. What do you find? So let me ask both of you, what is the thing that you find best about MDD? Like, how is it the most helpful? And then what is the thing that's most frustrating about MDD?
Maybe I can start. I think the most helpful is in these challenging cases where everyone kind of has a non-diagnostic situation, right? Where radiology's kind of there, but kind of non-diagnostic. Pathology is kind of there, but non-diagnostic, and the clinical side also the same, right? And so, because everyone has one piece of the puzzle, right? And each of us don't have enough pieces on our own to say this is what it is. But when you take everyone's one piece and you put it together, then you get enough to paint the whole picture and put it together. And I think that is the idealized world of MDD. but as we all know, that often is not the case, right? Where that, it's things are still in the gray zone,
Yeah.
and there's really not clear evidence of one thing or the other. And those are some the most challenging cases I find, is when there's just not enough in any one thing, and we don't really know what's going on, and it's frustrating because you feel like you're just at the same point as you started, and you're just kind of making your best educated decision of where it is. But
Exactly. Same for me. Irene, what's your best and worst for the MDD?
It's a bit. I like when there are so many times that what we see has nothing to do with what the radiologist says. That it's crazy because it's the same patient and it should correlate. Then what I love is that the patient has a suspicion and the radiologist and I see a totally different thing. And when this happens, it's like magic. Oh, I saw the HP. So.
cool.
And that's the what I like. And what I dislike is sometimes that they want to push a bit a diagnosis, no, and you feel a bit pushed, no, because well, if the biopsy has not if there is not enough tissue, or if there are not the features, you cannot say, and that's all, and we should all understand that. But sometimes it's like, oh, but it's clear that it has, well, but it's clear in the CT, but not in the biopsy.
Yes.
This is the part I don't like.
I agree with that. We are in a slightly different position than a usual laboratory professional. I think we've had this discussion before between the three of us. It's different than just reporting a calcium or a hemoglobin level, because the person who reports a hemoglobin can say it's 8.5, and I don't care what the clinical setting is. It is 8.5. And the problem is, although we also have a objective, right? We say there are lymphocytes, there's a granuloma, but then they can put some pressure on us to say what that means. So I think that's where it becomes a little, it's very, very open to personalities, to, interpersonal dynamics, your philosophy of things. It's just not pure science at that point. It's some sort of art / politics / slash just practical life. It's practical life of dealing with a difficult case where there is no answer, and you're trying to come up with something, which is very frustrating. I find that very frustrating.
I think that anchoring bias can be a challenge, right? Where the case comes in as it's this, and the first person that talks is very clear that this is what it is, and then that everyone else is trying to put it into that box and view the findings within that lens, right? And it's in an idealized situation, you want three completely unbiased opinions and reviews of it, and so that you're not stuck on that initial anchoring bias from the initial.
We have our reports done before.
Yeah.
But I always have to. I a lot of times have to make a note after the committee to just to know that I saw something. Many times I see things a little bit different after they say, not changing the diagnosis, but I like to write what I thought after the multidisciplinary discussion.
I have a question for you guys. Do you show the images of all the slides in the cases, or you just talk about the findings during the rounds?
We show images. For ILD. They find it helpful to see them. I'm not sure why, because I really think they don't understand what the image is showing. But they like to see it. They like to get some sense of, like I think Irene or somebody was saying, they like to get a sense of, is it mostly inflammatory or mostly fibrotic? Are there a lot of granulomas or just a few? I think they also try to read your level of confidence. They say, oh, this just seems like a slam dunk QIP, or like you're hesitating, you're describing a lot, which means you're not really, so I think it helps for them to get a sense of which way you're heading, even if there's no clear cut answer at the end. So I just like to show images. I think it does help in ILD, just to get everybody on the same page.
I also show always, and also sometimes they want to know if as we have cryobiopsies, they want to know if they ask for a surgical biopsy. If I think that it would be useful to, because there are some biopsies that I feel that I could see more if I saw more, and that's another thing that we discuss.
Interesting.
Yeah, same thing happens here too in our place also. They will ask us if we think that there's any point doing or what kind of biopsy should we do. Should we do a conventional transbronch or a cryobiopsy or a surgical biopsy? What is the differential? Will you guys be able to give that answer? There's a lot of like useful things that go on even in the non-diagnostic cases there. But
Sometimes we discuss cases that we have a biopsy from some years ago, and they have more CTs. Then it's like, what you see in the biopsy is what do we think that is what is happening now? Should we get another biopsy? This is another thing we discuss in these discussions, and it's interesting. Sometimes we decide we need a new biopsy, and sometimes we decide we don't.
Yeah, we show digitized slides for all the cases, so we can kind of give them that perspective of the whole slide, and we often do trichrome stains, not because you really need it for the diagnosis, but it often helps in these rounds because it kind of gives an overall sense of the amount of fibrosis, and it can be a useful low power discussion description to show the extent and the distribution of fibrosis, because it's basically green. Well, if you use a Masson's, like of all the green is the fibrotic stuff, and so it can be helpful for people who aren't used to looking at H&E.
Yeah, it's just not that impressive, I think, the H&E, because when I show the fibrosis on H&E, they're like, and then I show the same thing on a MOVAT, and they're like, ooh.
Yeah.
It's the same thing.
MOVAT is beautiful. We don't have this MOVAT.
Yeah, I don't know. The MOVAT's actually more expensive than a Masson, so so I often order Masson just to save some money. But I agree, the MOVAT's nice.
I demanded the MOVAT, and because I see some pictures in Twitter, and I'm envious, and I demanded they said they are going to try to put it for diagnosis. Let's see. Awesome. I don't know nobody in Spain that uses MOVAT. We use Masson, the blue or the green one.
Yeah, cool. Well, I think we're just coming to the close of the hour. I think this has been a great discussion. Is there anything else that anyone wanted to add in the last minute or two?
No, I think we covered pretty much everything.